Hi, everyone. Thanks for coming to our third town hall of the year. We are very lucky today to have with us Dr. Kelly Cowan, who is a pulmonologist at UVM, and nurse educators Rylee Austin and Melissa Barron to talk today about asthma specifically and all of the other respiratory illnesses. If you can we did send them questions ahead of time that you guys sent us. So thank you for sending those to us. If you have any questions during the presentation, please put them in the chat. And then there'll be a discussion period where you can raise your hand and we can call on you. So thanks for being here today. And without further ado, here are our presenters. Thanks for being here today.
Hi. Hi, everyone. Kelly Cowan. I'm one of the pediatric pulmonologists at UVM, and I'll start out the presentation, and we can feel free to put anything in the chat. Feel free to have me pause for discussion. We have, a handful of slides, so we'll have plenty of time to discuss. I think it's our first time back in a while being able to get together and talk about asthma. It's a lot of numbers of trouble with asthma has increased. We're focused on asthma in our presentation, but we're happy to talk about other respiratory things as well as we go through our presentation. Next slide. So I'll give a little overview of what we'll talk about today. Some of the pieces we were asked to talk about were the pathophysiology of asthma. And that will include a medication overview, including SMART therapy, which was an update to the asthma guidelines in 2020. We'll talk about asthma action plans, spacer and device use, and then we'll just open up for some cases in discussion about supporting students with asthma and how we can work together to do that. I incorporated the questions we got ahead of time, and we can incorporate the chat questions as we go. Next slide, please. So start with pathophysiology. So the NHLBI defines asthma as a chronic inflammatory disorder of the airways with recurrent or persistent episodes. It's associated with variable airflow obstruction, bronchial hyperresponsiveness to a variety of stimuli. So those are the hallmarks of asthma. And these are some images of what the airways can look like when they're constricted and inflamed. Next slide. And the important thing to remember that asthma is a clinical diagnosis, not in a lot of kids, especially if you can't perform spirometry or if they're healthy, there's not other diagnostics. So this is really based on the clinical history. It's not always straightforward, and presentation in children can be really variable. In very young children, we can't objectively measure lung function easily. The episodic nature and the variety of triggers can confound the clinical picture. There can be comorbid conditions that can make the diagnosis difficult or be a different diagnosis. And in infants, we often don't make the diagnosis until at least the second episode or exacerbation because the differential is a bit broader here. And I'll pause here and talk about one of the questions that we were sent ahead of time was about the physiologic difference between asthma and reactive airway disease. And then if a child is diagnosed with reactive airways disease, is there an age where it should change to a more concrete respiratory diagnosis such as asthma? And I would say that sometimes I feel like that term is used more to avoid the more descriptive term of asthma. And physiologically, this is the same thing. So when we're talking about airflow limitation to a variety of triggers, it doesn't matter on the age of the child. We would give a diagnosis of asthma in a very young child or an infant if they're having that pattern, they're responding to the medication, even if they can't do objective testing such as spirometry based on either their age or developmental ability. So that is okay if they have a diagnosis and clinically have a diagnosis of asthma to use that specific term at all ages. And there's not a physiologic difference, or the preferred term would be asthma for people with this physiology. Next slide, please. So symptoms, when we're thinking about a clinical diagnosis here, a lot of kids just have cough. Some have cough or wheeze, can have shortness of breath, exercise intolerance, chest tightness. Prolonged colds is one that we commonly see. This is probably the most common cause of recurrent pneumonia that we see is asthma. Certainly not the only cause of these symptoms, and kids can have a mixture of these symptoms, or they can have one of these symptoms. Signs of this can be none, especially if they're well. If they're acutely ill, can have tachypnea, wheeze, decreased duration on the exam, retractions, prolonged expiration, and increased AP diameter of the chest. The differential can be broad. It's not always straightforward. It can have infection, recurrent or chronic aspiration, CF, dynamic airway collapse, foreign body, vocal cord dysfunction, hypersensitivity, pneumonitis. The differential can be broad for these things. So it's important to think, well, what else is out there? You could be thinking of yet asthma being the more common condition causing these things. Next slide. So the common triggers for kids, the more common things we see, viral infection, probably the biggest one we're seeing these days. Smoke, particularly tobacco smoke, but also wood smoke in the home. Exercise, environmental triggers like pollen, third animals, air pollution, airborne chemicals or dust, dust mite, mold, pests, particularly mouse and cockroach in the home or other environments, changes in the weather, strong emotional expression in menstrual cycles being the more common things. Next slide. We'll talk a little bit about viral infections because that's what we're seeing just tons and tons of this past year and especially this season. Viral infections, particularly rhinovirus, can predispose children to develop asthma and trigger exacerbations. We're seeing, you see in the news and, probably in a lot of people, children with bronchiolitis, kids who are hospitalized with bronchiolitis have a high likelihood of going on to have asthma, or especially in the first, or recurrent wheezing with illness. And many of those kids go on to have asthma in their early years. Rhinovirus is one of the viruses most highly associated with asthma and persistence of asthma. We do see this commonly with RSV as well. It tends to persist earlier in life and, not as often later in life necessarily, but these are two of the bigger triggers. These are probably the more studied ones as well. We see this with other viruses in addition to those two, but those are some of the big ones that we're seeing lately. And some of the trouble kids get into is with their asthma is airway hyperresponsiveness after their viral infections. So when you have a single cold, the duration of the airway hyperresponsiveness can be 5 to 11 weeks. So you're looking at weeks to months here. And then kids get more than one cold in that time period. And after multiple colds that have irritated the airway can be reactive for more than 6 months. So this is some of the rationale for trying not to chase it with, here and there maintenance therapy, but really trying to focus on optimizing that through the cold season, through these multiple viral illnesses. And we do see that prolongation of virus-induced airway hyperresponsiveness in allergic kids might contribute to the asthma persistence. So that's definitely not uncommon. And I think that's one of the more common reasons we see in kids in clinic is because they're just not clearing anything out after illness. And I'm sure that you're seeing that a lot at schools, with kids, coughing for a long time. Next slide. So some of the objective ways we have to measure lung function would be spirometry, because the history and physical can't always characterize the degree of lung impairment, so the degree of airflow obstruction or reversibility. So we have in the first airway, here's the normal airway, things are nice and open. In the second picture, there's an inflamed airway affected by asthma. And you can see the picture that that's made with, this is with spirometry. So an exhalation is the top curve that looks like a triangle. And you get that scooped kind of ski slope slate shape from the airflow coming out more slowly when the air is obstructed due to asthma. And then we look for reversibility with albuterol for that. And that can be helpful diagnostically, but also it can be helpful in assessing the severity when kids seem to be doing fine. So I'll add in here, there was a question about, we're talking about objective measures of lung function. There's a question about peak flow measurement and why that seems to have been phased out on asthma action plans. And that's sort of a variety of reasons. It's a handy device. The pros are that it can be done at home. It's not expensive. The downsides of measuring peak flows is it's really effort dependent, and you need to do consistent repeat measurements over time with the same device. So it's not helpful, if someone goes to an ER urgent care, wheezing and short of breath and gets a peak flow, you already know that they're sick, and it doesn't necessarily change the management. And this is something for kids who are doing it would be like a twice a day thing at home. And what we see a lot is that if people need to have that measure, they really need to be focused on taking their maintenance therapy. And that one, it can be a distraction from doing that, but also adherence to that and then not changing management. So the other thing is that it can be helpful in some cases. So I think it's a good thing to know about as a tool. We don't routinely do it, and we don't routinely recommend it. So I see why it's, we don't put that on our asthma action plans. On rare occasion, we do, and I give some examples. So it can be a nice tool for a child who's a poor symptom perceiver, who just doesn't know. And if they're a motivated family and they're already taking their maintenance medication, that can be helpful to know when that's changed. And if they've dropped their lung function, and now we know. So that is helpful in that situation. And then another example is I have a patient admitted right now as a poor perceiver of symptoms. We think recovered from an exacerbation, just taking a really long time. Spirometry looks great, but just having a lot of chest symptoms, we just can't sort out why they feel like they're having tightening. And the peak flow might give some information about, well, is that what's happening? Is it bronchial limitation from their lower airway? Is it something with their upper airway? Are they having heartburn? Trying to sort out their symptoms. So in that case, that might be helpful on a very individual basis, measuring peak flow. The thing we found that also the meters are a little hard to come by. And that's something that we used to have them around in clinic in the hospital, and probably Rylee and Melissa can attest to today, we could not find one. So I think that can be a useful tool. And I think my thought process around it is for an individual patient, for their circumstance, that might be an additional add-on tool. But I would focus on the maintenance therapy, symptom tracking, education, and then spirometry for kids. Next slide. So when we classify severity of asthma, this is the intrinsic intensity of the disease, and that can vary over time. Most directly, we can measure that when someone comes in for the first time with suspicion of asthma, and we're going over the history, and that guides the treatment decision when you're not on any everyday therapy. Once you're on therapy, we can correlate the severity with what is the lowest level of treatment that it takes to maintain control of your asthma. The important thing to remember is that severity might not correlate with the intensity of exacerbation. So if someone has a diagnosis of mild persistent asthma or intermittent asthma, they can have a severe exacerbation. So their severity, even if it's a mild or persistent asthma, it doesn't mean their exacerbation can't be severe. So the domains of asthma severity and the domains of asthma control are impairment. So what's the frequency and intensity of symptoms and functional limitation? And then what's the risk? What's the likelihood of exacerbation, likelihood of decline in lung function, reduced lung growth? And then are you having adverse medication effects? So these are things that we review with kids. And there's ways to classify, severity and how often you have asthma. I think the simplest way to think about is, deciding whether someone has intermittent asthma, where you're just needing rescue therapy, or persistent asthma if you're needing maintenance therapy. And it's easier to break it up into those two pieces. I think sometimes there's a lot of terminology out there like cough variant asthma, and some of those are helpful to think about, just pictures like, yeah, you're coughing a lot after colds and things like that. But it also makes it a little bit complicated to think about, do I have to know all these different kinds of asthma or how to treat those different kinds of asthma. I just tend to simplify whether it's intermittent asthma and you can treat as needed for symptoms, or if it's persistent asthma and you need to be on an everyday maintenance therapy. Next slide. So the goal of assessing asthma and monitoring asthma is to reduce the impairment that a child experiencing and reduce the risk of exacerbation and adverse effects of therapy. And one of the important ways we follow this is assessing asthma control, and that's the degree to which the manifestations of asthma are minimized and that the goals of therapy are met. And after you're on therapy, we do have this emphasis on, how do we maintain your therapy or how do we adjust your therapy? Do you need to go on more therapy? Do we need to add on because things aren't going well, or have things been stable for several months and we need to think about, is this a good time to step down therapy, or is your pattern where we should keep things the same? And with this, our goals are always to reduce symptoms, reduce the functional limitation, improve quality of life, and then reduce the risk of adverse events. Next slide. So I think these are probably things we see a lot in our clinic, see a lot in school, that adherence is a big thing that affects how kids do with asthma and how well controlled their asthma is. Most of these are social factors that affect that, but there's a lot of things that go into that. So mental health definitely affects asthma control, whether they have exposure to tobacco or in the home, or personal exposure to tobacco or other substance uses, including vaping. The safety in the home, food security, are there multiple homes or caregivers? What's the level of supervision or assistance for medication? I think that's probably a big one we see, because kids, as they get a little bit older, developmentally do a lot of things. They can probably cook dinner, they can do a lot of things around the house. And it seems like there's not a reason they can't push the button on their inhaler and do that, but it doesn't happen. And that's a developmentally normal thing for kids to need assistance and parental supervision for that. And I think we found it helps, I think, reassuring families that that's developmentally normal and they're not alone, and that we're trying to promote them being a team with their child, and that the child, would have to accept that supervision. But that's a hard one. It's a lot of work to do. We see a lot of barriers to obtaining medications, cost, transportation, refills, pharmacy issues, insurance issues. It's really hard, I think, on our end when we're prescribing and we find this isn't covered, but we've tried a couple medications and we know we need a specific one and can't get it, or it's going to take some time with a prior auth. That's a challenge. Our families been to the pharmacy, but then they have to go back. So I think there's a lot of barriers there with the medications, and we try to minimize that with phone calls and things early on, but it takes a lot of time and it takes a lot of attention to each individual child. Schedule for medications can be a factor, whether when they get up in the morning and what's going on in the evening, changes in the home environment, who's taking care of the kid, medication beliefs at different homes, medication beliefs in one home. Are they worried about medications? And if they're having any side effects of medication. So those are things that we assess. Things that sometimes overcome a few of these is thinking about, on occasion, there's some children that really benefit from administration at school. Have a lot of really grateful families who have benefited from that. Other things we find is like having them bring into clinic their medications and devices, and then checking their refill history. It's not always a negative thing in the refill history. There's some patients that are using an empty inhaler and they really are taking it every day. And we found that sometimes we check the history and they haven't refilled it in 3 or 4 months, but I definitely believe they're giving it. And we find that they're using an empty inhaler at that time, and we can take the opportunity to review those pieces. Next slide. Next, I just go over what factors for children are associated with an increased risk of exacerbations or death. These are kids with severe airflow obstruction on spirometry. Not everyone can do spirometry, so the other factors are still important. Kids who've had 2 or more ED visits or hospitalizations for asthma in the past year, if they've had an intubation or an ICU admission for asthma. And then there's certain demographics that make people at higher risk. And then psychosocial factors, socioeconomic factors, and then attitudes and beliefs about taking medication. So mostly that would go along with the non-use of inhaled corticosteroids. Next slide. So we'll talk a little bit about medications. I have a lot of slides about specific medications and things. Some of them are a little bit dense, but we'll get through, and just sort of for the sake of completeness, we'll go through in a little bit more detail here. Yes, and I'm checking the chat a little bit while we're talking here. Rylee will go over with the slides, but yes, we definitely want the prescriber to pick the right thing and instruct the parent on what they should be expecting. Yes. So for medications, the treatments that we have are effective to control symptoms, reduce airflow limitation, and prevent exacerbations. Over time, there is risk of airway remodeling. Chronic inflammation can lead to irreversible airway changes and premature decline in lung function. That's one thing we want to put our time, mainly for kids. We're preventing, exacerbations, risk of morbidity, mortality, risk of missed school. So some of those pieces in the acute period, and in the long term, identifying kids and keeping things under control over time, so they're not having those other risks. So the long-term goal is to treat the disease. So that's with maintenance therapy for kids who need it. And then for quick relief medication to treat acute symptoms and exacerbations. Next slide. And I'm seeing Amy's questions. Let's talk about this. Yes, that's a really important question. We'll talk about that shortly with the asthma action plan. So the first line of therapy for kids for maintenance therapy is inhaled corticosteroids. And we're looking at this. This is the most effective maintenance therapy. It treats the underlying problem. How this works, it binds intracellular glucocorticoid receptors that affect inflammation, upregulate beta-2 receptors. It blocks late phase reaction to allergen, reduces airway hyperresponsiveness, and inhibits inflammatory cell migration and activation. It improves asthma mortality rates, and it's been shown to decrease exacerbations, hospitalizations, ED visits, symptoms, airway responsiveness, obstruction, and increases symptom-free days. I think I had a question ahead of time about what differences there could be in interventions for eosinophilic asthma versus non-eosinophilic asthma for the most rapid improvement of symptoms. I think first line either way is inhaled corticosteroids. We're going to move on next to talk about inhaled corticosteroids and LABA. Getting the inhaled corticosteroids on board, usually giving that a few weeks for the steroids to be really effective. Some kids respond to that sooner. With a long-acting beta agonist, they generally get symptom relief right away. And this tends to be more predictably effective. And kids with eosinophilic asthma is a little more predictable, but that would be the first line treatment for eosinophilic and non-eosinophilic asthma. And I will share a slide later on about biologic therapy really briefly, and that's something for higher level therapy that would target that specifically. Next slide. So now we'll talk about inhaled steroid and long-acting beta-2 agonists, or ICS-LABA. And the examples of the LABA are salmeterol and formoterol. We don't prescribe those alone. They don't come alone. That's not a safe plan for children, because then you would basically be on rescue medicine all the time, and you actually need something to treat the problem, which is an inhaled steroid. So these come in a combination inhaler. Inhaled steroid and LABA combination inhalers are more effective at controlling symptoms and improving lung function than inhaled steroids alone. Inhaled steroids plus leukotriene inhibitor, and more effective than doubling the inhaled steroid dose. And so obviously the plans are tailored by patient, but in tolerance of things. But this is a nice option for kids. It tends to be pretty helpful in kids who are having a lot of nocturnal and exercise symptoms, and a lot of albuterol use tends to work well. You can get some tolerance to these medications, so we're going to be mindful of whether they could take a pause or how they're doing with the therapy and if it's working. Next slide. So acute therapies, mostly what we'll see, in our plans for school or short-acting beta agonists with albuterol for acute symptoms and for prevention of exercise-induced bronchospasm. And these have a rapid onset of action and it relaxes smooth muscle. They're inhaled usually with a spacer. There's some devices that don't use a spacer, usually better tolerated the ones with a spacer. These aren't for chronic use. There's generally no advantage with levoalbuterol. It can reduce the heart rate by a few beats. Usually albuterol is as well tolerated. So that would just be a more individual decision if someone is on it, levoalbuterol versus albuterol. I'm going to talk about in the next pieces of the text, smart therapy, so inhaled steroid and long-acting beta agonist as single maintenance and reliever therapy, and then how you might see that being used. Occasionally there's kids on anticholinergics, so ipratropium. Usually that's more of an acute exacerbation piece, but there's some kids with some underlying condition or special circumstances where that might be a rescue medication. And then for moderate and severe exacerbations as an adjunct, we may use systemic corticosteroids. This is a good question we should talk about now from Jane, and we'll come back to more about the action plans shortly, about kids getting put on rescue inhalers with their upper respiratory illnesses, and then the long-term management of that. And how long should that continue without a maintenance inhaler? That's a really excellent question. And I think that's maybe worth some group discussion here about what people tend to do. I think I know what, I do in clinic and, and taking a history and how long it's been, on that, if they're needing it for one cold, that's a little different situation. But you guys are seeing that at school, if they're continue to come in and have that on a plan. Is there a certain time you would check in with their prescriber or with their parent and ask them to check in? I'll pause for comments.
Jean, did you want to unmute and talk about that because it's your question?
I haven't, it's been happening, I would say, increased over the last 2 weeks. So I don't think it's been long enough for me to have that conversation yet with parents or with a physician, but it's happening a lot more. So I'm just wondering what the long-term plan is for this, because I just see it being kind of an ongoing issue.
Yeah, I do think this will be, I'm not surprised that's coming up more. Are those kids coming with an asthma action plan?
Well, some of them have, and then others, it's been kind of a fight to get that asthma action plan. And I am at a school that is very proactive in doing all of that stuff. But for some, it's been really hard, and even getting a second inhaler so that they have one for at school and one for at home. And I did want to ask again, I thought I heard you say at one point here, and I don't know if this is still true for the elementary kids, that for some, a spacer is not necessary for some inhalers.
For all of the HFAs, they're necessary. They do make Pro Air, actually they're not making. So I'm looking at my slide outdated a couple months ago here. But these inhalers, so now there is one that looks like this Pro Air one. There are Pro Air Respiclick inhalers or Max Air, some of those that are a dry powder inhaler that are made to be used without a spacer.
Okay.
We've noticed here, I've heard from some of the pediatric residents, and I've seen it come up in people who are in the Epic prescribing system, that I'm seeing this on even little kids, like a 3-year-old getting prescribed this and they can't do it.
Right.
And I think it's an issue in the medical record where that pops up as the first selection. It looks okay. and then the parents get it and it's one that doesn't go in the spacer, and the prescriber wouldn't necessarily know. So there was a little issue with that. So I think that is important. What device do they have? Is that intentional? And their technique with it is really important. But yes, we, in general, aside from those kids, most will tolerate the spacer and chamber mouthpiece, or the, or the mask.
Right.
It has to be the device specifically without it. I definitely wouldn't recommend doing it without. Thanks for that clarification.
Yeah.
And back to your question, if I think it's good, if they come with an asthma action plan, that's better. That's a better thing if they have those medications, because it does it's a little more clear. The parent knows why they're taking it, and and the opportunity to check back in. I think I feel comfortable if you're thinking like, I'm treating them for intermittent asthma and they're needing it for, a couple times a day for a week after this cold, and they're not very often. That would feel better to me, but I think we might find that these kids, like now next week they have a cold and they're not coming off this medication. It's worth another discussion of, do they have follow-up for this? I've gotten that call as a parent from my child, from their nurse when they were in first or second grade and going in a lot for their inhaler. I got a call, that they're coming every day, and
right.
And that was helpful for me to know. And my child was asked about what was she taking at home in the morning, and the nurse was worried it was albuterol also in the morning, because it looked the same as her school inhaler, but it was Symbicort. But it was really helpful to know, and then get her medication adjusted from getting that call.
Okay. So, I mean, because like I have a student and she's been on one for like 3 weeks now, and she's been taking it like every day or every other day at school, at least once, sometimes twice. And so, I'm like, okay, is this okay? How much longer do we keep going like this? Or
I would say, potentially not good control to me. And I think it would be someone I would want them to be reevaluated.
Okay.
If it's our patient, send them back. I would want to reevaluate that.
Okay. All right. Good to know. Thank you.
Jane, that's usually my limit too, like 1 or 2 weeks. And somebody's continuing to come in often, I usually just call home. And I don't know, it sounds like Kelly, you agree. I just call home and I say, when was the last time you were seen? And, based on the frequency, would you please consider going in? And I've definitely had a handful of those kiddos come back with Flovent or something prescribed, and all of a sudden they're much better.
Yeah. Yeah, it's worth a discussion. And then I'll see Kara's question about the asthma action plan and exercise. She says that the plan sometimes indicates 10 to 15 minutes before exercise. The order needs to be followed. However, there can be gray areas with some students who stop showing up or say they don't feel like they need it. If the parent or child say leave it up to the student, would you recommend an asthma action plan update? Yeah, I think so, because I do try to talk to that with parents before deciding how to write that part, and then what ends up being helpful for school, because if I write in a plan, before exercise as needed, sometimes that ends up being too confusing, or the child doesn't feel like advocating for themselves, or sometimes that's the right thing. We know that the kid definitely needs it right now, but they might not need it after their Flovent kicks in or something. So I do try to ask parents to check back in if we need to update the plan. I think it's worth doing that so everyone's on the same page if you aren't taking it or you'll just take it sometimes. I think that's worth the update. I know it's more.
Doesn't that also depend on when they have PE? Like, so if they have a daily med and they have PE first thing, it may be that their daily med just hasn't kicked in fully yet versus
Yeah,
if they have it later in the day.
Yeah, it'll depend what they're taking. If they took, if they have that first thing in the morning, then it depends what it is. If they need albuterol pre-treatment, I think if they have taken, a Symbicort with a long-acting beta agonist right before school, that might cover them okay. Not for everybody, but a lot of times it will. So I think it is helpful to think through on the timing. That's something that we've appreciated from the nurses, is that I feel like most everyone's pretty helpful about figuring out for kids, like, what's the most convenient timing if you're sick, or what is going to work best if we can cover you for gym and recess without making 2 trips, or if you're someone who takes your Symbicort or Dulera in the morning, and it happens to be for a gym, you might be all set, to get it all done at once. So I think, I do think that's helpful, and I do think it's worth adjusting the plan so it works for the school. So I think it's worth it. I know it's extra, someone adjusting that, but if it should save time and energy for everyone all around if it just gets updated. I'll add one more thing on this acute therapy side, because there was a question about that there has been a decline in PRN nebulizer orders, and is that because maintenance medications have improved? Yes, I think a couple of things is, I guess how you look at that. One would be, there's good maintenance therapy, so overall, hopefully people come for bronchodilator less. But for the nebulizer specifically, the spacer and the inhaler are as effective for almost everybody. Not, there's some kids who just do seem to do better with nebulizers, and that is okay. In general, the medication gets in better with the spacer and the mask, and sometimes it's a dose issue and they can take more puffs. And if a child always needs more puffs, that should be on their plan. It's worth adjusting that. So I think that's probably more the decline in the PRN nebulizer orders. Also kind of seems like a hassle and takes a lot of time. So when the spacer is just as effective, we go with that route. I prescribe nebulizers if people really want them or have them already, or if it works better for that child, or if they keep showing up to the ER to get a neb, and it's definitely helping. And I would not ever deny someone that, but typically if they have a nebulizer and they're prescribed an inhaler, most people shift to that because it's just so much easier. My next slide. I'm going to look at Clayton's question here. I feel this happens a little bit on any urgent situation. It can happen. It happens sometimes with hospital discharges, a little bit of take this until you see pulmonary in a month or something. That's like way too long. Or take this until you're back. And if you have a primary care visit in a few days, that makes sense. But yeah, the taking it, they'll be instructed to take that, but there isn't, the parents might not know what the instruction is for when to stop. I think it definitely is really important for to be with their primary provider about that additional guidance. But yes, I agree. There should be additional guidance and there should be primary care follow-up for that. Especially for parents who don't know or haven't had to do that in a long time. We'll talk about smart therapies. This is single maintenance and reliever therapy. The only medications this is recommended for is inhaled steroids and formoterol. And so those medications are Dulera and Symbicort. That's the only ones. This was an update to the asthma guide, the NAPP asthma guidelines at the end of 2020. And it's been in the GINA guidelines for adults for quite a bit longer. So this is something to consider for moderate to severe persistent asthma, and things that may come up on an action plan or some variation of this. And I think it's a nice way to use the medications as they function, the pharmacology, like, and how it works to try to, control things better. This is not necessary if kids are well controlled on inhaled steroids and LABA and as needed short-acting beta agonists. So you don't have to do this if kids are doing great with their normal plan, or that the smart therapy is cost prohibitive. It's like usually a long discussion. It's supposed to be a really simple thing and straightforward. You just have one inhaler, but it's pretty complicated in kids sometimes. So it's not a requirement, but there's a high certainty of evidence to doing this in age 12 and up. Moderate certainty in age 4 to 11. Only study with formoterol because this has a rapid onset of action and safety profile. Salmeterol has a really slow onset of action, so you really can't use it as a rescue, and it does not have the same safety profile. This would be for kids who are on maintenance dosing of 1 to 2 puffs once or twice a day of ICS formoterol already. And the maximum dose per day, and this is something that should be on the plan if they're using this, would be 8 puffs total in a 24-hour period for ages 4 to 11. And if they're over 12, it's 12 plus total in a 24-hour period. And I'll have an example of an asthma action plan. There's multiple ways to do this, but I'll have an example of one that I shared with a child recently. Next slide. So to touch on some potential issues with this. So definitely no, this is not for Advair. So if someone's on Advair, cannot do this. And there's reasons that I tend to prefer Dulera or Symbicort just to have this flexibility. It makes it so much easier when you're troubleshooting an illness with someone at home, or you have some other tricks up your sleeve to do. But there's some kids who need Advair for one reason or another, and you just can't do this. It's really important in monitoring and follow-up here because it's hard to check refills, because normally, like, well, if you're on maintenance medication, you don't have to check, it's great if you're refilling that, but this is harder to, follow up on. Are you refilling a lot of albuterol? If you're not taking it, then it's a little, the checking system is a little more individualized. It's not always clear whether insurance will cover more than one ICS LABA per month. Generally they do, but sometimes it's a cost issue, or how do you prescribe them? Because if someone needs their Dulera 2 puffs twice a day, that inhaler is going to last a month. They don't have extra to be taking more doses during an illness. They're going to need a second inhaler. And then if that happens, and if they're just using that, they're going to need a second inhaler for home and school. It's easier if you're an adult and you're just responsible for carrying your inhaler, and that, but I wouldn't want it on a child, if they lost their inhaler and you couldn't get another one, like that's not a great plan. So this does take a lot of work in our office to talk through about how does the plan work, what's most cost effective, finding out on our end, like, does their insurance cover 2 inhalers? A lot of times that's on the parents end to say, like, is my copay a lot, ridiculously high with the maintenance medicine, and albuterol is a lot cheaper, because that's fine. But it's that those pieces are really important, because they're going to have a rescue medicine in the places they are, and they're going to have to be able to have their maintenance therapy every day. So it seems very straightforward in the onset. You can just use the same inhaler for everything, but it's not always that straightforward. The other thing is that we tend to have some albuterol in hand, because for exercise, you're kind of using the medication for what it does. So that the long-acting bronchodilator in the formoterol lasts about 12 hours. Sometimes people don't want more medication on board for 12 hours and rather have the albuterol on for a few hours. So there's reasons to have more than one inhaler for exercise-induced bronchospasm. So next slide. And we'll come back to smart therapy again, just with a example action plan. So just talk about a couple other medications that are often in the plan. So leukotriene receptor antagonists, most often this is montelukast or Singulair that we use. And it's a nice add-on for a lot of people. It's not effective for everyone. So that's one thing that we keep in mind, is whether it's working for them. Typically it's an add-on. It can be monotherapy for lower level therapy, but it works better. The inhaled steroids are better, so we tend to add this on. Most people know about this black box warning. That's important to know about behavioral or mood side effects or potential. It's about 3% of patients recorded. I feel like we see it probably a little bit more often than that. Do you counsel parents about that? Because it goes away quickly when they stop it. And so they do need to know what to look for. And do you use caution if kids have coexisting mood disorders, and if we can work with their psychiatrist or primary care, or someone if we think they're a good candidate for taking it anyway. Often try to avoid, but there's some kids who are good candidates for trying it with really close follow-up. Next slide. So LAMA, or long-acting muscarinic antagonist, or tiotropium. We use this for some kids. This is Spiriva would be the more common thing that we use, and as an add-on if their control is suboptimal on ICS LABA alone, or as an adjunct for kids who have a contraindication to the LABA. And so I think probably the important thing to know for this one, or one of the important things, is that this is an add-on and this is not monotherapy. So if kids are just taking their Spiriva, that is not okay. It's not, that's an add-on to the inhaled steroid. Sometimes that's an important part in our clinic, is that when you're adding this on, it's an add-on, not a switch. The pharmacies know this, they give both, but the patient family needs to know they have to continue giving both. Next slide. And I'm not going to go through this whole slide, but I think just for completeness that biologics for allergic asthma, these are injectable medications for allergic asthma. Since the question specifically about eosinophilic asthma, for kids with eosinophils, elevated eosinophils, would be Nucala, Facena, or Dupixent, depending on kind of the age indication where they're going to receive the medication, and then Xolair for elevated IgE levels for kids who are not well controlled on the other therapies alone. There's also immunotherapy that can be pretty life-changing in terms of the course of asthma and allergies. For kids who are not stable to receive immunotherapy, the biologics can be a bridge to that as well. Next slide. Okay, we talked a little bit about exercise-induced bronchospasm. That shouldn't usually limit participation in activities. Pre-treating with short-acting bronchodilators prevents exercise-induced bronchospasm in most kids. And if that isn't well controlled, we do really think about whether maintenance therapy is indicated, whether it's an inhaled steroid, ICS LABA, which usually work pretty well, or montelukast, or a combination. Sometimes see that in higher level athletes as well, that, things that, if they weren't doing as much activity wouldn't, might not need maintenance therapy, but they really might need to be on something else. And sometimes it's a marker of inadequate asthma control. So I think it's something to know, just sort of in your general assessment of kids coming in for inhalers. Next slide. So we'll talk a little bit about routine education on self-management. So we kind of, with families, can we go back a couple slides? Oh, next. Did we miss some? Can we go back to the slide on the routine education on self-management?
I maybe just deleted it by mistake. I don't know.
Oh, okay.
I don't know what happened. Hold on.
Oh, that's okay. You know what we could do? We could come. Oh, you got it.
Okay, we're back.
Perfect.
I'll just delete that from the recording.
That's fine. Because I can't draw. This is the picture I usually use on teaching for patients, is talking about what does the normal airway look like? What does things look like with persistent asthma? And then what does it look like when things are really inflamed and irritated? And this is right to describe about age-appropriate education on medications and how they work. So if you're on inhaled steroids, that works on that inflammation in the airway to make that more normal. And then when you're looking at treating the problem, when you're looking at rescue medications, that's looking at relaxing that smooth muscle to open things up. And this is a nice time to talk about the triggers, self-monitoring of control, symptoms, adherence, and symptom perception, and then figuring out what the treatment goals are, what symptoms you're aiming to reduce. Next slide. So the asthma action plan. So this is something that I think I'll bring up the question that came before the talk, because it was really important, that whether providers feel that action plans are effective and or necessary for optimal management of asthma, and if so, why do we receive so few? I think that's a really important question. Yes, I do think they're necessary for optimal management. It's a nice communication tool for self-management, for a care plan, and for communication between everyone involved in it. Gives everyone, like, everyone knows what this is and then where to put things. It's nice when building these to go through, for us to go through. I write it out with the family, review with the caregiver and the child if they're, old enough, which is most kids, like school age kids are all old enough. Reviewing their medications, what they're for, when to take them, when are you in the yellow zone? What are the symptoms, the pattern? Is it seasonal? Is it rapid onset? What are their triggers? Talk about symptom perception, and then the goals and what symptoms we're trying to reduce. And then what's the contingency plan if it's not going well? What are we going to do? It's really more important to have the copies for home, daycare, school, anywhere the child's going to go, to have a communication tool to be the same. And I think someone had asked about prescriptions for home and school. Yes, so they need a spacer for home and school. We see a lot of kids don't have that from the pharmacy, or maybe the pharmacy is not able to dispense that. I do think that's a challenge some places. That how we've overcome that in clinic is that we've just been buying them and dispensing them there, because if people don't have them or don't have enough of them, they just can't give it, and it's not going to work. So it's helped us teach as well, because we can get it out, we can show them how to do it, they can do it in clinic. I think it's been really helpful. So yes, I think that's important. I don't know why receiving so few. I think that's a good question. Does anyone want to comment on that?
I'll just add, so we do give them like 3 at least copies. I think, Kelly, you give them like 4. We do
Paper
get
wasting, yeah.
a lot from the schools. You can always call us if you don't have one, and it's very easy for us to fax one over. But I think communicating with the family too, we do have them call. I don't know if they lose them and just are unable to provide one, but we give them to them. So don't hesitate to call us to request one. We can easily fax it over.
I think if I'll just, this is observational just from discussions we've had in our district, but as the kids get older, so when they go from 7th grade through 12th grade, and they're mostly carrying, and they're able to carry and self-administer, we don't know everybody that has one in the school. And so, and it's not clear when they're supposed to be using it. Are they using it too much? Is it going to be a problem? And getting an asthma action plan for those, or the ones that every year say, my child still has an asthma action plan and has medication, but then doesn't necessarily have that because they don't want to lose that diagnosis maybe. And so that's where we struggle. And so if we think they still have asthma, we're required by our we have to report it annually who has asthma, who still has asthma, who has an asthma action plan. It makes it really difficult in tracking all that down. And so make anything that can make it easier for the school nurses. I mean, it's not just we want to do paperwork. We want to make sure the child's getting the medications that they need. And there's kind of a meeting of a mind there somewhere of ownership. And if you look at the law, I was looking back, and the law says that if you want to carry and self-administer, it's incumbent on the parent and the provider to make that paperwork available to the school, not the other way around. But that doesn't happen. So then the school nurse becomes that conduit to make it occur. So any help in that?
Something as easy as us asking every one of our kiddos that attends school to give us the school, at least the school name, and we can just fax one.
Yeah, that'd be awesome.
While they're here.
Yeah.
Because I think too, with the kids those age, the mom maybe sent them in, or dad, with the paperwork, and they didn't provide it to the nurse and it's still in their backpack. So that may be an easy fix for something like that.
I'll come back to Amy's question too about from earlier that in the office, do you automatically offer an action plan, second prescription for school? Yes. I don't know. I think most of the time for the primary care who's managing asthma, I would assume the same. I think sometimes, I think at least I get some new consults and people don't because it's new to them and they might not yet have had that second one prescribed. So I guess I don't know across the board how that happening, but yes, that does need to happen, that for where they are, they need a second prescription for school. And that's where for smart therapy, you know, that may be challenging, but albuterol is covered. They can get more than one at a time. Yes, many families did stop sending it to school after the start of COVID, saying that when they're ill, like they won't need it. Yes, it's not the case anymore. Yeah, I think it seems like it's going to be a process with getting things, you know, back and going and everything back in the office. I think it's been a challenge too when a lot of kids were well for a couple years. And then, you know, over the past year, maybe some symptoms are emerged or they haven't been really sick or not needed it. And there may be questions about whether their child has asthma, you know, or is still an issue. I had gotten a call from my middle schooler's nurse to ask to bring her plan in. I had filled out the school forms that she didn't need it, but I appreciated the check-in, you know, to whether she does. And then, you know, we decided together, like, it's been 3 years, you know, she's not seeing anyone for asthma, no medications prescribed. Like there wasn't a reason to go get any medications. But I do think that that's going to be a bit of a process, and probably some of those kids who really did need it a few years ago and really didn't for a couple of years, that's now emerging that, you know, everyone's needing this again. And I think, and I'm sure that there's some backlog in getting seen or getting, you know, the medications re-prescribed and stuff, because we're getting a lot of calls as well of kids who need to get right back in. And I think our process is more of like, we'll just make the action plan, then get you in for that and do the refill. But it's some of these kids, it's been a long time. Is there a way we can help with those kids?
I have a comment. I agree. For some people, it has been a long time since they've been in, or what I'm seeing now, I'm new to working in a high school. I had only worked in elementary and middle school previously. And then the high school, there's that level of independence. And I think Clayton was talking about this also earlier, of just throw it in your backpack. You know, so a lot of kids are bringing inhalers in their backpack and not telling us, and the parents have fallen off the wagon of giving us an action plan. And it may be a combination of what you were just talking about, though, is that they also are at an age where there was a perception that they had outgrown it, and now they're needing it again. We're definitely seeing a lot more high school students coming in for inhaler use than previously, and many are coming in and there's no inhaler there because they stopped. So it'd almost be nice for school nurses to be able to take our, like maybe in our electronic health record, if we have it, run a report on everybody that has asthma and send a letter to all primary care doctors at the beginning of the year that says, you know, this child has asthma in their history. Would you like something on file? I don't know. Because we've got probably 50 kids in the high school that have it on their record that don't have anything at school.
And we don't know if they do, you know, still have necessarily the active stuff. That's a hard age too, because I also think about the kids and their symptom perception, whether, you know, like, have they had follow-up of that? Like, do they still have asthma? And the ones that do, how often are they taking a rescue and just have it? No one knows. I see Kara's comment about noticing more often the action plan indicates 4 puffs. This is helpful to have in place, especially with students who may not be well managed. Kara, is that a comment to have that for kids who might need 4 puffs, to have that option?
I'm sorry, Kelly, can you ask that again?
Oh, is that question about it's good to have the option of 4 puffs?
Oh, it is, yes.
It?
Yeah, and I've just noticed that over the last like maybe 5 years that's been more. It always used to just be 2 puffs. And now it's 4 is on
Yes.
and it's helpful. Yes.
So I think the tricky part here is it's like probably a just provider preference a piece, but I put this on my, it's not a we don't have like on our smart forms a range. I don't think, maybe Melissa and Rylee know, I think I have to delete and free that text that. But that's my preference. I think some people will just keep putting 2, but I think to me, a lot of kids need 4 because if they would take a nap, they would take 4. That's pretty normal. It's not an emergency in most of the scenarios. It's just what they happen to need. And I think if they're in the yellow zone, the parent also can say this or that this week or whatever you need. And that's makes it so much easier than asking. And I think some people have a higher range. Like just Melissa and I were talking about this earlier. This is going to be a style. You get to the same end result, but it's like how much work for everybody. And then is it a lot of anxiety for the parent if you're now giving 4? Because that should not be exciting unless they're having trouble breathing. But some people do 4 to 8 puffs there. And it just depends like what's the teaching for the family. But I agree. I like to have the range. And I think that's a fine thing to ask for if it suits the kid. It's fine to ask to have that updated. I'm going to go to the next slide. I think this is sharing about an example of smart therapy. So this is one that I think, if for smart therapy, this is just one example. The goal of this is to be able to just use the same inhaler. And we talked about the caveats here of, can you get an extra Symbicort, or are you really not used to this plan and it kind of freaks you out, or what do you do? So for people who are sort of switching over to this plan, or who can't get necessarily more than one inhaler, or their extra albuterol for school, or their extra inhaler for school is albuterol, I will put on the plan an option. So you might see this action plan in the yellow zone. So this is a 16-year-old who's on Symbicort 80, 2 puffs twice a day, and then they do not pre-treat for exercise. They have no exertional symptoms. You could add treatment in here if you wanted to. But this child, I did put an option here for, albuterol 2 to 4 puffs every 4 hours, or the Symbicort option. You could just not even have albuterol here at all. You would just take out all this middle part and just say Symbicort as needed. But this person, I gave an option. So any of those options that you have would be fine. If you see that on the plan, it has to be Symbicort or Dulera. I have, for some kids who are just not doing the smart therapy, but sort of a variation of that, in home, and that wouldn't necessarily be for school, but it could be, if their dose is 2 puffs one time of day of Symbicort, I will have them take it twice a day when they're sick. It just makes sense because they should sleep better overnight and that, but they really might only need it once a day for maintenance. It's a little variation of that, but this would be what you'd look for, is that they have a maximum of how many puffs for their age. It's a 16-year-old, so their max puffs would be 12 puffs in 24 hours. You might see some variations in how often to give it. I would be flexible here. It's fine. We're happy to be a resource if does this make sense or look okay? And maybe it's ours you have questions about. But this is really, individual. And we might say for a younger kid, 1 puff as needed in that. So really the point is, if you're on 2 puffs twice a day of Symbicort, that's 4 puffs you've taken up in the day. Then you have 8 puffs to do whatever you want with over the next 24 hours. Sometimes we see it with the LABA lasts longer and might hold them better. Maybe they don't need so many puffs. The every 4 hours, people tend to feel comfortable with that on the family end. But it really could be, they could do 1 puff, they could do 2. So it's a little tricky. How do you dose this? We tend to, families just tend to like some sort of interval. So whether we're telling them to take it 3 times a day, something, but this is just an example of what a plan might look like with the smart therapy.
So Dr. Cowan, I had put a couple of questions specific to smart therapy in the very beginning of the chat.
Yeah, I'll come back.
And that was before the folks joined, so they won't all be able to see those questions, and I can repost them if that would make sense. But I don't know if you want to look through those. I wasn't really familiar with smart therapy until I had two different students, one with Dulera, one with Symbicort, and then I was reading the package instructions, and you can't use this.
Yeah,
inhaler. So
yeah. Package instructions are like dicey for all of these. Like no one would take any Flovent in the package instructions. Yeah, so I think that the labels haven't changed. This is guideline based therapy. That's important to know. The most things for children are like often not approved. A lot of Medicaid are not approved for children, and this comes up where with inhaled steroids with LABA for a 1-year-old, like not that often, but it comes up, or a 2-year-old, not that often, it's not approved. But this is guideline based therapy, and you can share with the pharmacist, like the guy. That's why I prescribed it. It's not out of line with guidelines. I mean, that's how I'm following them. But yeah, so this is guideline based. It would be an order, to give it, and it can be on their action plan. It's interesting. Yeah, they probably should state they're not intended as used for rescue inhalers, but that is what this is used for. But the intent is with it as maintenance therapy as well. Though it does give a buffer for kids who are using it, as needed for that. But that's not necessarily the first line of, use for that. But we do that sometimes too. So I would say that part is probably good for people to know that this is intended, maintenance therapy, but with smart therapy, it's same maintenance and rescue therapy. And it's basically, how the pharmacology functions and the onset of the formoterol. But that's a really good point. And then I think the same with some, yeah. Yep. The comment. Should I read that, Clayton?
Yeah, I think because I don't think everybody can see it.
Yeah, it's like, can it be used as a rescue? Both the manufacturers have statements they're not labeled for this use. Dulera is not a rescue and should not be used to treat sudden severe symptoms of asthma. And Symbicort says does not relieve sudden symptoms. Always have a rescue inhaler medicine with you to treat sudden symptoms. I think this is where this point requires a lot of education with the family about that, of how to do it. I've found it's not been that straightforward either when it's a family new to asthma, and like that should be a fresh time they're not familiar with any plan. So it should be easy to make a new one, but it's not that straightforward either because of all those caveats. Like you still need, do you have enough inhalers and exactly how you use it and how do you monitor it? So I think I like it. I think it's nice to have a flexible plan, but it's a lot of, education and being very specific with what to do. It's also been helpful. We've had kids call, during the pandemic, they haven't needed anything around. They're having an exacerbation, no albuterol in the house. They're pretty sick and they got a whole pile of Symbicort. Then you have something you can do for them while you're getting them to the ER or whatever you're doing for them. But I think this is probably an education piece on like, what exactly am I doing and then how do I follow it? The third question that Clayton had, and this is as we're moving on to the next things about spacers. I think you can go to the next slide, I think. Just make sure, yeah. About Clayton asked about guidance giving to parents regarding Symbicort, guidance that the company gives to throw away Symbicort 3 months after you take it out of the foil pouch, whether it's explained to them when the prescription's written, and does the prescription provide sufficient refills to support both home and school. So yeah, we try to provide the refills for home and school and parent education about cost and this and that. I have only gone by the expiration on the container, to be honest. So I will have Melissa and Rylee comment as we're going, and if anyone else wants to comment on that 3-month piece, because it's always out of the foil, but I go by the expiration on the device. I haven't had that be an issue, but maybe that's something we need to look into.
We talked a little bit about it earlier because even our albuterols that we use in clinic for the PFTs, we do the manufacturer date. That's really what we've kind of always been taught, is just to go off of that. So whatever is on that box, I would go off of that. I've never heard of the 3-month, but that is something we could probably look a little bit more into.
But just Symbicort doesn't have an expiration date, at least the one that I have. There's no expiration date on the actual inhaler. So, and so it might be on the full pack, but as soon as you open it up, you won't know unless you're smart enough to write it on there, which I wasn't.
Right.
So that's just something to keep in mind. Okay, I'll take a look because I didn't pull it. I didn't pull
There
it
you go.
completely out. So that's good to know. Okay, thank you.
Okay. Oh, you're muted, Kelly.
Oh, that's probably good. I was muted. It is on here. This is my personal one, not one I prescribed a patient and not my child's, and it is expired. No, my kid's not on that care, so I don't need to send a plan in, but this is mine, and
if you pull it apart, you can see the.
Yes, if you pull it up, that's my point. I should refill. I am aware of this. I wouldn't give it to a child. I don't recommend doing that, but also I store it very carefully.
There you go.
This is my smart therapy one, not my maintenance. Anyway, I'm gonna hand over to Rylee.
Yeah. So kind of to answer your question, Clayton, from the beginning about like the different brands for the spacers. Kelly, correct me if I'm wrong. Usually you guys try to do like the Aero Chamber brand when you submit.
I think we say, I go with, I'm familiar with the Aero Chamber. That's these, you guys see a lot of these, but there's the purple ones. And I tend to write like pediatric Aero Chamber or equivalent.
Yeah.
And then Rylee is showing, or Melissa's showing in clinical, like, what is it? So the parents need to look at the device so they don't get handed a baby one.
Right. That's something like I usually try to tell them when we're going over it. Maybe a different color, look a little bit different, but whether it's the biggest thing is whether it has a mask. Like if we sent for a pediatric one with a mask, they're not getting one with a mouthpiece. So it may look a little bit different, but essentially it's the same. I think Jane had asked earlier about using the spacer, and then Spiriva kind of came up. That's maybe one that you wouldn't, or you may see in school that you will not use a spacer with. So you're just going to use the HFAs with these guys. And really the two that you'll see most are probably these two with a mouthpiece or a mask. Around 5 is when we try to introduce the mouthpiece one. That being said, we definitely have some kids that are on the mask for a little bit longer that can't necessarily hold their breath for 10 seconds, or it's just that their technique is off, and it's harder for them to use that mouthpiece one. With the mask, I think someone wanted to just like go over like a review of how to use them. I of course don't have an actual HFA with me, but stick it on the end there. With this mask one, like I said, 5 and younger, so some of the school nurses that are with those kiddos, is really just making sure that they're blowing all their air out first and holding it up to their face. And with this one, the biggest difference is that it's going to be 6 breaths that they're going to take for 1 puff. Whereas with this one, you're going to give them 1, or they're going to self-administer, and it's going to be 1 puff, and having them hold their breath, slow deep breath in, and having them hold it for 10 seconds. So you definitely will see this a little bit with the older kids that are able to use that, but they should always be using their spacer. We do have a lot of kids that come in that the PCP maybe didn't give them a spacer, or they think that you grow out of it. We hear that a lot, that they don't need that anymore. And often the provider will review with them and keep them on that same maintenance inhaler, and their symptoms improve because they weren't really getting a lot of the medication prior without the use of the spacer. And then also reviewing if you guys do have kids that are taking like Flovent or any other maintenance inhalers where you're going to administer them at school, is to make sure that you're wiping around their face and having them at least swish their mouth. We usually tell them to do it before they brush their teeth in the morning and at night, but if they're at school, just having them rinse their mouth out, at least if they're taking one of those maintenance inhalers. at school. With albuterol, you can rinse your mouth as well, but it's not as, you're not going to get the thrush from the albuterol.
A comment about cleaning. Do you want to comment on that, Rylee? Do you recommend weekly
Okay.
cleaning being necessary?
Yeah, I say if they're sick, to definitely do it more frequently. They are super easy to clean. Just taking like this end off and warm soapy water and letting it air dry. But I would say weekly. That way you would say. And if they're sick, maybe more.
At home, we try to, if they can stockpile and have a spare one around, because it takes so long to dry. It's got to air dry, so that can be hard. And I think at school, if you're noticing that their technique is poor with spacer and mouthpiece, it's great to work on it. Some kids just need to keep working and just don't quite get the hang of it though till they're a fair amount older. It's fine to ask their provider to send the mask back in, or to stick with the mask for bigger kids if that's what works best. I think then it may be a question should they be doing that for their maintenance medicine at home? Rylee has a bigger size mask. I think for that really adult, most elementary kids, even big ones, even a 10 or 12-year-old, okay with this. If they developmentally can't, or just can't do it, that just go with whatever works. That you can ask them to send whatever in.
And sometimes if they're sick, if they're on a mask, I just wash the mask piece. If they're sick, and that's kind of easier, so you don't have to do the dry and wash and air dry, you just kind of are washing the mouthpiece. That's really where their kind of snot is kind of touching and stuff like that. So sometimes it's kind of a quicker way to do it, so it doesn't impact too much of their daily life.
Clayton, so is the Opta chamber the one that you held up?
Yeah, it's that purple one.
Yeah. You feel so a couple of the last two students, both 3-year-olds.
They should have the mask attachment to that.
So 3-year-old.
A lot of 5-year-olds will need a mask attachment for that.
Yeah.
Right, but it's also single breath. Hold your breath.
Right.
Right.
Yeah.
And so they can't do that either. So they're not getting any medicine, but it's really, and the parent went back and then got the mouthpiece for it too, but the child doesn't understand at 3 even how to breathe in through their mouth or nose and hold breath.
No, be a mask.
Yeah, right. And the Opti chamber really is the better. I mean, not the Opti chamber. I'm sorry. The Flow View is a much better one for the youngest kids, and it just isn't clear if the pharmacies know that or they just pull whatever's on the shelf.
Gotcha. I know we try to specify if the size of the mask or if it's a mask or mouthpiece, but I don't know. Yeah, some pharmacies may just totally look past that.
Yeah, they might.
I think parents need to know what they're expecting to get.
Yeah. We definitely during our spacer teach let them know which one. If again, it may be a different color or look a little bit different, but if it doesn't have a mask and they're prescribed one, give us a call so that we can touch base with the pharmacy at least to get them one with one.
Sometimes the insurance coverage is not very good for these. I think a lot of the insurance will charge full price, and the $60 or something for one of these, and that's not feasible. So they really do need to know what are they expecting to pick up if they're paying out of pocket for it, so they're not getting charged for something and then it's the wrong device. And then for the bigger kids, we use ventilator tubing to do spirometry, and they can use that and kind of cram the inhaler in there. For the chamber thing works fine. It just doesn't work for the mask part.
So then just listing the ones that you will see not as often. I feel like we try to fight insurance and not have them prescribe these, but we do have kids that come in that were already on it, prescribed by their PCP. Some of them are okay with the technique with the ones that are breath actuated or dry powder. But those ones you're not going to use a spacer with. And then Kelly, you had said, I usually tell them if they can't find the Boston Children's will have a video on it. If that doesn't work, usually I think they can just go to the website of whatever. And there should be a video instructing them.
Yeah, I try to watch it together, at least know what link they're
Right.
doing. I found that I did a resident teaching for the devices, and almost all the devices Boston Children's have is just Google that YouTube and then the name of the device. They have the specific one and a child doing it, which is nice. But the otherwise a company website is just like wading through the ads and things. But that's the other places for the unknowns.
Yeah.
Lots of institutions have them. I think that was, I just found to be like easy,
Yeah, that's
short, and then
new for, I like that
Yeah.
they have that on there. So that's good to know. Especially for you guys probably won't, which we honestly don't even see them that often in clinic because the providers try not to prescribe them unless sometimes it's an insurance issue or the patient is able to take it. But if you are unfamiliar with one of the like breath actuated ones, the Boston Children's has the instructional videos.
Yeah, I definitely have to do it. Some of them you have to put together or things that, and I'm not as familiar with all of them, and I'll just watch it with the patient and we'll like get the device and do it together.
Yep.
If it's a new one.
I think that's it on this slide. Yeah. Do you guys have any? Okay. Next slide. So these are just the ones that you guys would see most often. The Ventolin, which you'll no longer see ProAir, maybe for some of the kids until it runs out, but ProAir is no longer. For the rescue inhalers, the Proventil and Ventolin are circled. Those would be their like short acting bronchodilators. And then again, if you pop down to the inhaled corticosteroids, the Asthma and Flovent, either one of those, you guys really don't prescribe outside of those unless, again, insurance is pushing back.
Yeah, right, yeah.
Yeah. And then the combination medications. So Advair, kind of off to the side, that one was, Kelly had mentioned, is not going to be smart therapy. And then Dulair or Symbicort. I don't have much to add on this. I think it's more just a visual.
The only thing, the only thing I have is that what's tricky is that we were finding out if you ask the kids, like, what color is your morning inhaler?
Yeah.
And they may say red, which is Symbicort or ProAir. So it's really kind of tricky. I don't like how they did that. So it's harder to kind of tease out if trying to figure out if they are on an inhaled, kind of combination inhaler every day, and if they're taking it and which one they're taking. So it's really confusing, but that's why Advair is great because it's purple. So that's why sometimes it's nice to have this in the office and we have the families look at the pictures because Symbicort does look different when you're looking at the front of it, but so I guess it's harder nowadays to.
Yeah, I have this in an email, Clayton. I think that it doesn't have the latest ProAir updates. I think it's from the summer. This is probably the prior one, but it's the same medications. I can email that copy, and then Kara said you can get a big poster of it too. And we use some of the ones that aren't on here. I just put an X over the ones that like we just don't ever use in kids. Some of the other ones will show up from time to time. Go to the next slide.
You don't want to do this one then, right? So I like this poster. This is another one that I would recommend printing out too for your kiddos. It just shows why you use a spacer. Oftentimes, as the kind of theme is throughout the day, it's like families or kids say, like, why do I need it? This is why, because they're not getting it. It's not going to their lungs. It's not going all the way down to their lungs. They're not getting the medicine. It's not just not working. So this is a nice picture to show them that if they don't use a spacer, they're basically, I always tell the kids, they're basically giving it to the air, their lips, their tongue, their cheeks, the back of their throat. And then finally, I feel trickle down to their lungs. And that's not what you want, right? So this picture is just really good to show why you need a spacer. And I tell families, you need a spacer 0 to 102. So it doesn't matter. You never age out of a spacer. Oftentimes we are giving out those corrugated tubings to grandma because she doesn't have a spacer, and they think they don't need them, but everybody needs a spacer. So this is kind of giving kind of some reasons of why you need it. And as we talked about before, checking the counter, making sure that the kids or families know that they have a counter on the back, and then it goes down. 0 means it's gone and empty. So sometimes families will come in and be like, well, it says 0, but 0 means empty. And obviously getting the right mask and spacer, and then, you know, rinsing out your mouth after your morning meds, and then supervising. Sometimes parents, it's kind of our spiel that we give is we tell families to keep their meds in the kitchen. I say keep it in the kitchen, and you do it with breakfast and dinner. And so you don't forget. It's hard to, you shouldn't, just because you're 10 or 11, you shouldn't let them be on their own to do that. So we kind of tell families to kind of keep it in the kitchen, do it with breakfast and dinner. Doesn't matter if you eat dinner at 8 a.m. and dinner at 4 p.m. It's okay. It doesn't have to be exactly 12, so they get hung up on that. So that's kind of this little quick slide. You can move on and see what's next.
I think it's nice that we covered some of these actually. And as we went, we talked about, you know, things on our end that have been so nice to work together on is, you know, occasionally kids will need something at school. We appreciate very much timing of like how, you know, what works best for the child's schedule and, you know, to minimize extra treatments at school. And then checking on some of the self-management education and with the kids, especially if they start coming in a lot. I think a couple of things to discuss, and then I'm sorry we're so short on time. We can take more, you know, cases and topics as well. But thinking about like how we can be helpful if you're worried a student's asthma is not well controlled, and the next steps about that, and then what other questions are that you would like, you know, providers to do or, you know, want us to know. I think if there's not other questions, we'll take any other. So I saw the message from Moria. I'm just looking back in the chat about orders for stock albuterol. Does anyone's school do that already?
Yeah.
Does anyone in Vermont do it? Becca?
Yeah,
can you tell us about that?
Well, so I have a provider that writes us standing orders, and they put in an order to the pharmacy, and they put my name in as the patient name, and they just order 10, one for each of our buildings. But it is expensive, and so we do it through Costco to get the cheapest rate. But it is an expense for your school district. And in some school districts like mine, where you have to have a PO before you can go buy something, it becomes even more cumbersome. So I had to buy it myself and then get reimbursed. And that was a bit of a tricky, it's tricky because it's just not the way that our school district does stuff usually. But that's how we do it. I'd love for a program to be out there like the EpiPen program from Milan. It would be really helpful. I don't know how we get that or advocate for that on a national level, but it's definitely, it's not easy to do.
I agree with you on costs being prohibitive, Becca. We have a provider who writes standing orders for our schools, but actually this year the cost was prohibitive in getting them at all of our schools. So we prioritize middle and high school because those kids are most likely carrying their own. So it's rare that we have them in our offices. Elementary school, they tend to keep them in the office, so they have more of them, but I agree that would be great to have a program where schools could get them. Kelly and Melissa and Rylee, I have a question for you. I forget who brought up earlier, kind of looking at, you know, when do we want to reassess kids and have them go back to their PCP or to you folks if they see you, that we're recognizing that their asthma might be poorly managed. And I don't know if you have any resources for school nurses kind of little cheat sheets, or I know it's hard because it looks different for a lot of different kids depending on their treatment and their course and their triggers. But I don't know if there's anything that we could share with school nurses.
I think it's tricky to figure out like what's not like too, too involved. Like just, it seems like the clinical judgment piece is probably, when it's sort of, they're coming in as outpacing what's on the plan.
Right.
That might be, the time. I think there are, those charts of classifying your asthma control. I think one is like the asthma control test, doing those. But that's tricky because most of the time you're encountering kids who are like just getting over a cold. So of course their scores are terrible. And if you're going back and assessing serially, that, is that too long? But I do think if there are patients, just reach out when your sense is like they need to recheck in, because we can give a call to the family and check in, and reinforce the teaching or decide, do they come in or do they have a nurse call? Do they just not been in a while? That might be a little bit more often happening. But I do think it's worth getting those kids back in. I think that's going to be happening a lot more often, and it's probably time, and it's going to be a little bit of a rough patch getting everybody back and into the routine of getting seen again. But I think it's sort of that group of things, and I'm open to I think that might be worth another discussion, group discussion about how to get some of those kids back on track, and what's the easiest way to do it.
Just looking at our time, we are 3 minutes over. If there's any last question, we'll take it, but if there are none, going once, going twice, going 3 times.
Do spacers need orders?
I just yeah.
Under the wire.
Yes.
Do they? They should just go with the.
I was gonna say we don't like
plastic.
write them on the asthma action plan, but I don't think so, right? Because it's kind of.
I think they need them for Medicaid.
Okay.
If they have Medicaid, they do need an order because it's a separate cost.
I think the plan says spacer. Well, the pharmacy order, we do order them for the pharmacy.
Yeah.
They are, because you can buy them on Amazon. I mean, it's not a prescription necessarily, but insurance covers, so you can prescribe. And ours aren't prescribed, we just hand them out. They're plastic. We hand them out to anybody, Medicaid, not Medicaid. I don't know, we have it on the asthma plan as a teaching tool of reminding, be like, use your spacer. That's more of a teaching tool. I didn't really consider it as an order, but I guess it is. It's the communication tool. Are people ordering that, Kara? Or not? I don't know if I'm ordering that. It should be on the.
I've
on action plan.
never had a problem in elementary because I always require them, but I've just always been curious. Like, I know some schools have like stock, the little cheapo spacers and.
Oh, right.
I think, right? I don't, but if you have albuterol in your school, do you keep a stock spacers? Yeah. I was just curious.
That's like we use that tubing, but yeah, we have it in the office and you use the tubing if we're administering there.
And Lori just wrote, all of her students are on Medicaid and they do need orders to get them, because they'll pay for it then, and the family won't have to pay for it.
Well, I order it from the pharmacy. I just on the action plan.
Yeah.
Like I assume that it goes with the med. They need to do it, but yes, they definitely get a prescription at the pharmacy, and for sure, everyone does. They can decide whether they want to get it. Yeah.
Yeah.
We also don't really get pushback, I don't think, for spacers either. I don't know if we've they don't need prior auths or anything usually. I think almost all insurances will cover one.
Yeah.
But we do give them out like candy sometimes.
Hard to keep in stock.
Yeah.
Well, thank you so much for coming and speaking to us today. It was super informative and very valuable information to help us in our practice. We appreciate it. So Thank you so much, Dr. Cowan, Rylee, and Melissa. We appreciate your knowledge and expertise tonight.
Thanks for having us. Please reach out if there's more questions or however we can help, okay?
Yeah, thanks, guys.
Thanks so much.
You.